Thank you, Elizabeth, and thank you, Duchenne Care Conference, for having this space for backers. It's always the neglected sister somehow, so we're always happy when we're invited to talk about Becker muscular dystrophy. It's always a complex issue, and these guidelines started actually as an Italian thing in the very lively Italian Duchenne Parent Project team, but then it was clear that we had something that might prove useful also for in other countries, and translations um, were devised. And I really have to thank my mentor, my longtime mentor, Elena Pegoraro, for being the mind behind the whole document and the whole work. And first of all, this is a document for patients, but of course, it's not meant to be used for self-diagnosis in any way or for the self-prescription or of drugs or diagnostic tests. Also, this is a kind of disclaimer, so I'm now remember that I forgot to put a slide about my conflict of interest, and I will say to that effect that I've been involved in clinical trials, but also in some speaker events or advisory boards with companies that are working on treatments for Beckers, which are Italfarmaco and Santhera and Edgewise Therapeutics. And we'll touch upon those treatments later. So I think we need guidelines because when patients hear of a diagnosis or a potential diagnosis, they Google it, and so they might find a lot of things. Sometimes they're helpful, but most of the time they are not. So we wanted to have something handy that they could find on the internet that gave all the, we think, correct and necessary information. And I also try to be cool and have a QR code in my presentation, like Anamika. And so from here, you can directly get the PDF in English. There are also German versions and versions in a few other languages, of course, the original Italian. And you see that we have devised sections recollecting the usual multidisciplinary approach to neuromuscular diseases, which we are now strongly used to. So diagnosis was the first chapter. It's also the one that I wrote. So I, of course, I like it very much because like Anamika said, everybody loves their own work. And how could you suspect Becker's because of muscle weakness that the patient presents with, or maybe more often because even in the absence of weakness symptoms, um, occasionally you find elevated CK in the blood, or because the patient has a positive family history. And of course, this flow chart seems quite complicated, probably is, but whenever this suspicion is raised, probably it's better to refer the patient to a neuromuscular specialist. And of course, if someone has a known Becker's muscular dystrophy case in the family, it's probably better to test directly for the relevant variant in the dystrophin gene and confirm it or disconfirm it. And if not, if it's a new case without family history, probably the best test, as for all dystrophinopathies, as for Duchenne's, as for carriers, is MLPA checking for large deletion and duplications in the dystrophin gene, which can identify in Becker's actually a lot of cases up to 80 or even 80% or even more. And I must say that the role of muscle biopsy may have gone down a little bit since the time that these guidelines were first drafted, because really, even in the last 4 to 5 years, the accessibility of uh, sequencing through next generation sequencing has become so much easier. So sometimes we skip the muscle biopsy and go to gene sequencing, which is now more accessible. But I would like to stress that Becker's disease is a disease where you have some dystrophin, and the amount of dystrophin can bear some importance in the prognosis. Of course, it's also important to differentiate Duchenne and Becker's cases. So muscle biopsy can be relevant, and you can always go back to it if the sequencing results are not clear. And then you have some more advanced DNA analysis that you can make if the usual MLPA and next generation sequencing for the coding sequence of gene, which makes the protein, are not conclusive. And in the guidelines, you will find that we define 4 sub-phenotypes of Becker's, meaning that patients that have any male patients that have any dystrophinopathy, which is milder than Duchenne's, may be labeled as Becker's, but this could be a misnomer, or it could be could make things less clear, because you could call many different things Becker's muscular dystrophy. And in particular, I like it that in this more recent guideline document, we use the same 4 groups that had been defined in the 90s by many of my mentors, which are depicted here. Elena Pecoraro is here on the right, and Professor Angelini and Marina Fanin. And in particular, there are patients with dystrophinopathy, which I would not even call Becker's muscular dystrophy, because their disease is virtually subclinical. They don't have clear weakness. They usually have high CK, and they might have cramps, myalgia, or myoglobinuria, meaning that there is a sudden muscle breakdown after some sort of stress, like a fever, temperature, infection, or exertion. And group 2, the benign group, is patients having mild weakness, but not at risk, at least not in immediate years, to lose ambulation. The moderate group would be actual Becker's muscular dystrophy, the category for which this name is more apt. And these patients have a progressive muscular dystrophy with a risk of losing ambulation in adult years. And there are some severe patients who might be closer to the Duchenne spectrum, so to speak. And it's also interesting that the milder the muscle weakness is, the more likely it is that the patient exerts strenuously and so develops cramps, myalgia, or myoglobinuria. And to remind you all that it's quite easy to have particularly mild Becker's cases, there's a little clinical pictures. There's a little 2-year-old boy with a CK of 1900, and he walked in normal time. He has slight hyperactivity, like many kids of 2. He also had an EMG. And this is his deletion from MLPA, and we know that this is a in-frame deletion, so expected to give rise to a short dystrophin, so Becker muscular dystrophy. Mother is a carrier, so if you want to widen the family genetic testing, we go to the maternal grandparents, and grandma and grandpa like dancing in these dancing agonistic competitions. So obviously they're very well off for 60, 70-year-olds with their muscles. But turns out that unexpectedly, grandfather is not a carrier, but affected with a dystrophinopathy. And also in his later years, at his age, CK is not even elevated. It's normal to just slightly elevated. And probably he might have had higher CK when he was younger, because muscle changes, we contract with less force, we exercise differently. And so the title of this paper said, Grandpa and I have dystrophinopathy, just to remind everyone that dystrophinopathy might be very mild. And so you also have to sometimes test asymptomatic males in families. And as I was alluding to before, the 3 levels of analysis start with MLPA, then go to next generation sequencing the coding region of the gene, and just for selected cases, CGH arrays, which look for smaller rearrangements, or analysis of the transcript, which need a muscle biopsy, might be useful. But usually with just these 2 tests, we can diagnose 99% of Becker muscular dystrophy cases. It's very important to counsel patients and their families, also bearing in mind the psychological aspects that this counseling has, and give them information also how to conceive healthy children. And there are several approaches now available for that. And from now on, I think I'll just skip quite fast through the different sections, and I ask also the organizers to interrupt me if I go over with time, because I haven't kept track. And because through the QR code and also through an easy internet research, you can find the document, and so you can review it for yourself, and it's all there. And the main reason for having neuromuscular and neurological control visits is that your muscle strength and function is controlled by neurologists and by physical therapists through dedicated scales, but also through tests like functional tests, time function tests, muscle MRI. Of course, these are the same measurements that usually come as outcomes in the clinical trials, but are also useful to track the clinical trajectory of a patient. And this is an example of a section of a natural history study that we've run. So we were looking specifically at a group of patients with one of the most common mutations, a deletion, for example, of exon 45 to 48. And putting all these patients together, you see that we see some patients declining earlier. So this is a functional score, the North Star Ambulatory Assessment, declining as early as 20 years in some cases, but in most patients after the age of 25 to 30, and progressing quite fast after that, giving relevant disability because patients in the low range of this measure have issues climbing stairs and walking independently, or risk for falls. And just to give you an idea of the reality of these measurements, I'll show this patient who has good axial and neck strength, but he struggles very a lot with climbing a step, and also his stance can be, his balance is reduced and his gait is waddling with some compensation in advancing his steps. And he's also a very good power wheelchair hockey player, by the way. And I thank him for being compliant in having this picture shown for didactic purposes. You can see the weakness in the thighs, not being able to extend his knee completely. So that means a relevant risk for falls, and how his arm strength is very well preserved in comparison, for example, to intermediate Duchenne Becker muscular dystrophy or even Duchenne muscular dystrophy. And bone health, of course, this chapter is somewhat reduced in comparison to Duchenne, because I'm assuming here that talking about Becker's muscular dystrophy, we usually do not prescribe glucocorticoids to this patient. So a lot of the osteopenia and osteoporosis we see in Duchenne's derives from glucocorticoids, but for those most severe patients who are in a wheelchair, we know that all patients with weakness and reduced exercise, reduced load, mechanical load on their muscles, they do develop osteopenia, so you have to take care of that. And also from a bone health standpoint, in a more general sense, you might use orthesis in order to keep the alignment of joints and the range of movement of joints. And in the non-ambulatory phase, with the appropriate aids and orthesis, it's important to maximize the functioning and autonomy and independence of patients. And fractures may happen, of course, even if patients who are not treated with glucocorticoids. And as in Duchenne, we have to remind that fat embolism can be very dangerous in any patient who has a long bone fracture with a muscular dystrophy. And also, I'm happy that Dr. Weber talked before me, so you already heard many of the endocrinological problems that come up with glucocorticoids. But minus the glucocorticoids, we have to remember that these patients are at risk for malnutrition, for example, or reduced exercise, immobility. So obesity and diabetes might be issues, and it's important to ensure proper nutrition, proper intake of micronutrients, supplement calcium and vitamin D. Exercise is good. There are several scientific studies showing that yes, muscle is fragile, but moderate to quite vigorous exertion is good for muscle and also good for cardiac function. We only discourage patients from very heavy loads in weightlifting or very long and like marathon-like exertion types, but we encourage them to move and to play sports as long as they're able, or to play inclusive sports if they have more important weakness, because of all the beneficial consequences in not only muscle but also metabolism, heart, that you see here. And I'll now skip maybe a little faster, but I would just want to highlight from this slide that is taken from the guidelines that it might be obvious, but when patients are weaker and at risk for falls or in wheelchairs or use walkers, it's important to adapt the environment and educate them to prevent falls, which might be ruinous. And usually, as a rule, it is rare for Becker muscular dystrophy patients to develop full-blown respiratory insufficiency that might need non-invasive ventilation or even invasive ventilation, as it is more, unfortunately, the rule for the older Duchenne muscular dystrophy patients. But those patients who are closer to the Duchenne spectrum might develop that. So we usually monitor FVC and FEV1 through spirometry. And as a rule, patients who are ambulatory usually do not have severe respiratory insufficiency, but we also have a high surveillance level for example, nighttime apneas, because those might also come up with patients who are not as weak, maybe because of pharyngeal obstruction or because of overweight. And so we usually recommend yearly checks of these parameters. And for the weaker patients who do have full-blown respiratory insufficiency, as for other muscular dystrophies, non-invasive ventilation is recommended. And also other interventions such as assistance for cough in order to ensure airway clearance, and be very careful about oxygen therapy in patients who have use an IV, for example. You have to be very careful to only use oxygen when they are ventilated in order to avoid respiratory depression. And cardiac management is so important in Becker's because you might have that dissociation between the muscle and cardiac phenotypes. There is a thing called X-linked cardiomyopathy, which means that muscle is healthy with dystrophin defect, but the myocardium suffers very much. So even those patients with the milder forms of dystrophinopathy might have a severe cardiomyopathy, which might be the presentation reason. And in order to check cardiac health, the usual tools are ECG and 24-hour ECG and echocardiogram. But also it's very useful to use MRI for some selected patients, or even for all patients at certain stages. And there are several drugs, as you've heard before, that can be useful, and there is no substantial difference between the indications for cardiac drugs between Duchenne and Becker's at the same level of heart failure and dysfunction. And fortunately, we have so many effective drug classes so that we can combine them and choose depending on the patient status. And importantly, in those patients who become dependent from hospital therapies or have full-blown heart failure, we can direct them towards third-level treatments like ventricular assistant devices. These are, of course, very demanding surgical heart surgery treatments that can be applied in order to treat selected patients. And heart transplantation is quite common, relatively common in some cases of Becker muscular dystrophy. Now there are also some reported cases in Duchenne, but for Becker's, it's considered a more common indication. And of course, whenever the ejection fraction is very low, below 35%, or we have evidence of dangerous arrhythmias, defibrillator may be recommended. There are guidelines for safe anesthesia and surgery in all neuromuscular diseases, and in particular, dystrophinopathies follow the same rule that gaseous anesthetics and succinylcholine for muscle relaxations are not indicated, but you can find the full indications in the document. And also, it's a good idea to carry around an emergency card so that even if you have to undergo emergency surgery or emergency treatments, the doctors can be informed. And nutrition, as I mentioned before, is very important, but now probably because of time reasons, I'll go a little faster. And maybe stop for a second on the issue of psychological, neurocognitive, and psychiatric aspects, which can be quite important and might be divided in two different chapters. So one is the fact of living with a diagnosis that implies weakness and some degree of disability and progressiveness, and also the burden of maybe passing on the condition to loved ones through genetic heredity. And all of those things need support and counseling. But also importantly, there are several dystrophin isoforms arising from different exons and promoters in the gene that are also expressed in the brain and nervous system, especially the full length DP4 to 7 protein, but also the shorter DP140 and DP71. These are the most important for brain. And in Becker's muscular dystrophy, these could be altered somehow. And we do not know exactly how and to what extent they are expressed when they're altered, but we know that in dystrophinopathies in general, there is the possibility to develop a central nervous system syndrome, so to speak. So language delay, meaning later acquisition of some language skills is very common. And then there is an increased risk as compared with the general population of several neuropsychiatric conditions like the autism spectrum disorders, obsessive compulsive type disorders, but also depression and anxiety and attention deficit and hyperactivity. And in a few cases, also more relevant, more structured and profound intellectual disability. And in my clinical experience, I've seen some patients who have had this kind of presentation, maybe have developed schizophrenic disorders later in life. And probably there is some multi-factorial cause here because these disorders, of course, are also present at high level and a relatively high level in the general population. So it could be that the dystrophin problem is just one hit, and then there is another set of biopsychosocial factors determining the outcome. And BMD is still not very well characterized for this in this regard, but more and more literature is getting out there. So we'll probably know more in the next years. Also, I'd like to mention the BIND program in Europe, which will probably give a lot of interesting information about this. And the reason that we're interested in the mental and brain health of these patients is that despite weakness, we want them, we would like them to succeed socially and functionally and to be autonomous, to work and to raise families. And of course, it's crucial to start early and ensure the best education possible. So to ensure support in the school environment. And at the time of transition to adulthood, try to empower these young men and give them the ability to, for example, live alone, develop autonomy, and participate in social activities in many different ways. So in the document, you haven't seen anything about approved treatments because there were none, and there still are actually technically none, but now there are more formal natural history studies, and we encourage patients to participate in them, but also clinical trials. And you've heard speak of vamorolone, Givinostat, also another drug which reduces or tries to reduce damage due to exertion and contractions of a symptom is coming out and is leading a large phase 3 trial in Becker's, and probably others will come up. So we hope that when we are called on to revise the guidelines in a few years, there will be also drugs to include as a standard of care for Becker's. And of course, a lot of thanks to all the authors and also to the patients, and in particular, Antonio, who is a patient of ours, wrote a little preface. And I will not spoil it for you by reading it word by word, but read it because there are very insightful words from this very intelligent young man who is our patient. In particular, he says that there is now no cure, but a lot of things to do, and he valorizes the various aspects of disease, and I'm very grateful for his words. Thank you.